speaker, Dr. Kenneth Candido, my favorite man with biceps. Can you see them? All right, he's a professor of clinical anesthesiology. He's the Pain Fellowship Director and Pain Clinic Medical Director in the Department of Anesthesiology and Pain Management at Advocate, Illinois, Masonic Medical Center. And are we all ready for Dr. Candido's fun fact? It involves like and subscribe. Dr. Candido's fun fact is that he has a strong social media presence, including a YouTube channel with almost 1,000 subscribers. Also on TikTok, he is. Okay. It shows his world record of 269 football throws made into a basketball hoop, each no less than 45 yards from the target. It's never been done before and likely will never be done again. Dr. Candido.
Thank you. That's one of the benefits of having teenage kids. They teach you all about social media. So I have maybe 1,000 followers. My daughter, who's 17, has about 200,000 followers. We're going to talk a little bit about a zebra in chronic pain diagnosis. When I was assigned the topic, I kind of had to ask myself, is CRPS really a zebra? When we hear hoof beats, do we think about horses or do we think about zebras? I guess it all depends on where you practice medicine, interventional pain medicine, for example. I have no disclosures as they relate to this topic, and I'd like to talk to you and give you a little bit of a historical vignette about CRPS, the history, because the history predicts the future. Past behavior dictates future behavior. Let's talk about how things have changed. We'll talk a little bit about dorsal root ganglion stimulation, the accurate study by Dr. Deere and Maggie McHale, which may change the entire landscape about how we approach this syndrome or this condition, and some of the changes in nomenclature as they've occurred over time. So is CRPS a rare condition? Well, by and large, most studies would show that the incidence, the number of new cases per year is about 5.5 out of 100,000. I practice in Chicago with 2.74 million people. That means in Chicago there would be about 150 total new cases of CRPS per year. And I'm sure some of my distinguished colleagues who practice in Chicago would beg to differ with me. Some centers see that many cases per year, but are they really seeing CRPS? That's the main question. In aggregate, there's a little bit of higher prevalence, meaning the total number of cases, but the National Organization of Rare Diseases, anyone ever heard of this entity, NORD, has classified CRPS as an orphan condition. That means in the entire country, there are less than 200,000 CRPS conditions. So what is CRPS? Well, we've known since the American Civil War, 158 years ago, the classic treatise of the Union officers, Silas Burr Mitchell and Associates, who described causalgia almost to a T. The description going back to 1864 is identical to what we know about CRPS today, although they called it causalgia. So we don't know anything about the cause. Even now, 158 years later, we still have very minuscule evidence about what causes CRPS. Burning pain, intense burning sensation. He described hyperalgesia, hyperesthesia, allodynia. Face becomes anxious. The individual guards the affected limb. And so if you go back to Wilder Penfield in 1937, he described the sensory homunculus. Homunculus means little man. The representation in the cerebral cortex for sensory nerve input is huge for the hand and for the foot. And that seems to correlate almost exactly with where CRPS occurs. CRPS does not occur in the trunk. I reviewed all the world literature for Steve Waldman a couple of years ago to write a chapter on CRPS of the head and face and found a total of 12 cases looking at 60 years worth of literature. Doesn't occur on the head or face, doesn't occur on the trunk, doesn't occur on the shoulder. And I've seen patients refer to me with the allegations or the supposition that they have CRPS in the shoulder. It doesn't occur on the thigh, rarely, very rarely. This is a condition of the hands and the feet, almost exclusively. And so there are misconceptions and false hopes, and we know that we've had only descriptors to define CRPS for us through history. Evans, an American in 1947, suggested that there was involvement of the sympathetic nervous system, but know for yourselves that there is no set of criteria, Budapest or otherwise, that stipulate that a patient's response or lack of response to a sympathetic nerve block defines whether they have CRPS. And I see this all the time. A patient referred to me, got better with a lumbar sympathetic nerve block, ergo, they must have CRPS. No, it's not defined by IASP, it's not defined by Budapest, it's not defined by any set of criteria. And In the latter part of last century, a group met in this very city, Orlando, Florida, and coined the term complex regional pain syndrome, and we still use that criteria today. And so the International Association for the Study of Pain defines a syndrome, a complex, a series of conditions somewhat unrelated to one another, with a disclaimer that it's a diagnosis of exclusion. Again, some of my colleagues would take exception to that and say that CRPS is a primary diagnosis. No, even the Budapest has a disclaimer. They have a due diligence to exclude from consideration alternative and competing conditions which can provide or give rise to similar, if not identical signs. Simply, we're going to go through some of them. And Budapest and IASP came forth with 4 criteria or 4 basic factors: a sensory factor, motor factor, vasomotor factor, and a pseudomotor factor. Ongoing issues with this diagnostic criteria: the fact that it's purely descriptive and relies upon clinical judgment. Remember, if you have a blood pressure in excess of 140/90, it's easy to define somebody as having hypertension. You have a hemoglobin A1C greater than 5.6, you can say that they're pre-diabetic or diabetic. With CRPS, we have almost no objective criteria. It's very ambiguous. And so the vagueness of these signs confounds our ability to be really objective about this condition. Furthermore, Budapest classifies allodynia as both a symptom and a sign. How does that happen? How do you have a condition of pain to touch or a non-noxious stimulus that is considered to be both a symptom and a sign? And so it's critically important to determine if a patient has this condition. We know the sensitivity is high, right? If everybody in this room complained of pain if I touched your hand, that would be 100% sensitivity. But what's the specificity? How do we eliminate false negatives from consideration? Budapest has done some of that. It's reduced the false negative rate, but not eliminated it. Maybe reduced it down by about 30%. And so if we prescribe medications to patients, they have side effects, patients can become addicted to opioids, of course, which there's no evidence in the peer-reviewed literature that suggests that opioids even work for CRPS. Cannabinoids don't work for CRPS. Things like antidepressants may work, but there are side effects attendant to their use. And so Norm Hart and Steve Gould were some of the architects of the 2007 Budapest clinical diagnostic criteria. And the diagnostic criteria for research came forth with the Valencia consensus-based adaptation of the IASP criteria. And then Chris Wells over in Europe, a big researcher, also looked at this and set standards for the diagnosis and management of complex regional pain syndrome, coming forth with 17 standards. What are they? The first standard is that we ought to be using Budapest because it seems that the Budapest has reduced the false negative rate. Not eliminated it, but has reduced it substantially compared to former criteria. Prevention, there are no standards for the prevention. We ought to be engaging our patients in a multimodal analgesic regimen. Get them involved in psychological support, use physiotherapy, and where appropriate, refer for peripheral nerve blocks. But remember, the level of evidence for peripheral nerve blocks is virtually non-existent. And that includes things like stellate ganglion block, that includes intravenous regional anesthesia. Certainly continuous catheters, like continuous epidural catheters, have no evidence in their favor, no hard evidence. Some anecdotal case reports, one series of 38 patients, for example. The final standard was that there is no standard considered as having sufficient support to recommend as mandatory to eliminate the condition. We still don't know what causes CRPS. So what are part of the differential diagnosis of CRPS then? What are the things that can confound us? What do we have as clinicians our duty to determine and eliminate? We've got to go through a checklist. Does the patient have local pathology? Do they have disordered arteries, disordered veins, thromboangiitis obliterans, Berger's disease, things like that, Raynaud's syndrome? All these things can mimic CRPS. In the old days, we used to say that syphilis was a great imitator. That was a medical condition before there was an identification of pathology and treatment. Syphilis was the great imitator. John Bonica in 1967 said that RSD was the great imitator, that so many things can look just like reflex sympathetic dystrophy. Peripheral nervous system conditions can mimic CRPS. Malignancy, how about factitious disorder? Are there any patients, for example, possibly in the workman's compensation system who are pretending to have CRPS? We don't know. We don't know with any degree of certainty. And of course, if a patient has proximal pain and complains of tactile allodynia, pain to touch in their shoulder, should they have CRPS? Probably not. If it's the proximal lower limb, should they have CRPS? Probably not. If they have no trauma associated with the condition or syndrome, do they have CRPS? Probably not. And if it's spreading, right? We hear about spreading from one limb to the next or from the lower extremity to the upper. That's probably not CRPS. Here's the other cases directly from my own patient profile. This is a nurse. She was 56 years old. She fell and broke her wrist. I saw her 18 months after this condition, and most of us in the audience could recognize edema. We could recognize color changes. There's also, when I examined her, severe allodynia could not be touched. Severe color changes, edema, temperature changes, motor changes, and alterations in the growth of hair or nails. She met all 4 objective Budapest criteria for CRPS. She has CRPS. Here's a case from my own. It was referred to me for an independent examination. Very interesting lady, 25 years old, working as a certified nursing assistant, fell in a hospital. Fell and injured her knee, and this is what she showed me when she came to see me for independent exam. She was seen at a major medical center in Cleveland and a major medical center in Chicago. She was seen by experts in CRPS. They all said that this was the worst case of CRPS they had ever seen. Refused to move her leg. She had this peculiar ecchymosis around her left knee. And her husband was a police officer. She happened to work, interestingly enough, in billing and coding for 7 years, so she knew a lot about medical diagnoses. No response to lumbar sympathetic nerve block. Well, there is no criteria that establishes you have to respond to a sympathetic block to have CRPS. On the corollary, even a positive response does not include you as having CRPS. She had a continuous lumbar epidural, no benefit. Again, no literature to support that practice, but people sometimes do it by consensus. No response to medical management, no response to physical therapy. The expert, the world expert, said this was the worst case of CRPS he had ever seen. And she came to me, refused to move her leg, came in on crutches. Well, guess what happened, folks? 2 weeks after my examination, she was seen on surveillance. Somebody once said that character is defined as what you do when you think nobody is watching you. And so surveillance video captured her running across her lawn, pushing her 2-year-old in a stroller, pulling a garden hose, doing hip bends, doing calisthenics on her lawn, and her psych profile, because somebody decided she might be a candidate for STEM, showed borderline personality. This person did not and does not have CRPS. Fascinating case of a 60-year-old lawyer who came to my attention. He had been a law student at the University of Chicago. He was standing at a bus stop outside of the University of Chicago when a gangbanger for initiation rights came up and shot him in the leg, severing the superficial peroneal nerve, leaving him with permanent impairment of eversion. He went to Thailand, created a very successful business, came to see me 31 years after the gunshot wound, and this is what I saw. I saw a foot that was shiny, that was red, loss of hair, atrophy of the right gastrocnemius, and you can see close-up of that right foot. If this person had read Wikipedia, as many of my patients do, and came in and said, oh yeah, the bed sheets hurt my foot, please don't touch my foot, he would have had CRPS, but guess what, folks, he had 0 pain. He came to me to see whether there was anything that could be done for his cosmetic deformity. He was like, he did not and does not have CRPS. He had an isolated neuropathic condition, a neuropathy to the superficial peroneal nerve. This is from some Italian investigators. They tried to look at why we have difficulty in rendering diagnosis of CRPS. This is about pediatric literature, looking at a comparison of Budapest clinical diagnostic criteria, research criteria, IASP and development criteria, and they found that over a 32-year period, there was so much disparity in what we consider to be objectified evidence, because everybody's using different criteria, development, IASP, Budapest, Japanese diagnostic criteria, etc. We don't know necessarily what the literature really means, but there is no level 1 or level 2 evidence for the diagnosis of CRPS, and that includes the Budapest clinical diagnostic criteria of 2007. This is a nice paper from our orthopedic colleagues. It's been suggested that CRPS follows total knee arthroplasty up to 21% of the time. 1 out of 5 patients who have a knee replacement could develop CRPS. And they found 0 out of 100 patients prospectively studied who met the criteria as having CRPS. This is a nice attempt by our surgical colleagues to minimize the overdiagnosis of CRPS. Don't forget that patients who do have CRPS, 16% of them will have severe depression, and 2/3 or 67% of them will have severe psychological comorbidities. They need psychological support. That's one of the mainstays of treatment. What are the things that can work? What are the things that don't work? Well, bisphosphonates may work early on, calcitonin later on. Dimethyl sulfoxide for warm CRPS, and acetylcysteine for cold CRPS. Steroids don't work. There's no evidence in the literature except that for short term they may benefit patients. Anticonvulsants have probably shown some benefit for CRPS. Antidepressants with a high side effect profile probably work for CRPS. Ketamine. With respect to Robert Schwartzman out of Philadelphia, who did a couple of nice studies that were very small. There was no placebo. The evidence is very weak for ketamine. So all of you who are using ketamine and rushing to establish pay-per-view ketamine clinics in your locale, the really evidence does not support the use of ketamine for CRPS.
Cannabinoids do not work for CRPS that have a prohibitive side effect profile. The levels of evidence for sympathetic nerve blocks simply don't exist. Most of it's anecdotal, most of it was never compared to placebos. Same thing with intravenous regional anesthesia, same thing for continuous plexus blocks, same thing for continuous epidural analgesic infusions. The best evidence that we have is not for sympathectomy, doesn't exist, or amputation, that's the worst thing you can do, but for spinal cord stimulation. You know, a debt of gratitude to Kemmler going back to the year 2000, I'll go quickly through that data. And then the dorsal root ganglion stimulator, the paper of Tim Deere and Nagy McHale, the accurate study of DRG from 2017, really may change the landscape of how we manage especially lower extremity CRPS. Peripheral nerve stimulation, we don't know anything about it yet. Transcutaneous electrical nerve stimulation sounds great conceptually, but if the patient has real allodynia, they're not going to tolerate the placement of pads over the affected limb. Non-invasive brain stimulation, no to low evidence. Deep brain stimulation, no evidence. And this is a nice paper from one of my good friends, Alan Kay, from a few years ago, looking at some of the modalities available. Vitamin C, a lot of the surgeons after a fracture will say, give the patient high doses of vitamin C. Well, guess what? There's no evidence in favor of that. Ketamine, very weak evidence. Physiotherapy, low quality evidence. It seems to make sense by consensus. Immunomodulation, poor quality studies. Bisphosphonates may be safe and effective. And of course, sympathectomy, no go. No data in support of that. Neuromodulation remains the gold standard for documented cases. And conventional stimulation and dorsal root ganglion stimulation seem to be the go-to therapies for CRPS. Here's your author here. This is your narrator showing one of my patients from about 2 weeks ago with 3 DRG stimulators, L4, L5, and S1. So Kemmler published a series of papers starting in 2000 in high-quality, high-impact journals, New England Journal of Medicine, looking at about 56 patients who had CRPS, comparing physiotherapy alone to physiotherapy with stimulation, and found that at 6 months there was a statistically significant improvement in pain in those who had stimulation and therapy. He took it out and looked at those who were not only improved a little bit, but who were improved a lot, and again, found statistical significance that neuromodulation worked. He looked at the same data over 2 years and found that the reduction in pain was 2.5 on an 11-point Likert numerical rating scale from 0 to 10. 2.5, which was considered statistically significant. Also, those patients who were much improved continued to be at a very high level. And so what happened at the 5-year period in Kemmler's series? Well, there was a drop-off. We call this habituation, where neuromodulation failed to derive those kinds of results at the 5-year period. It was still better than physiotherapy alone, but now the reduction in pain went from 2.5 to 1 on the 11-point scale. Yet when Kemmler queried his patients in 2008, 95% of them would have the same therapy again if they were offered the neuromodulation. So neuromodulation back then in 2000, 2008 was one of the best studies of whether or not neuromodulation works. One of my patients got this nice tattoo. I said, why did you do that? She said, well, my mother told me if I was in a car accident, make sure I had clean underwear on. And she said, also make sure that if you're in a car accident, somebody knows that you have something in your spine, which is probably a pretty good idea. The Compact Initiative is an international initiative to gather data, both demographic as well as physician-derived data on CRPS, and collate it. This was, again, the brainchild of Drs. Gould and Dr. Harden, and looking at clinician-reported, patient-reported, to avoid unrealistic expectations, to educate patients, to provide therapies, not unitary therapies, but multimodal, looking at maybe saving money with monotherapy, but being realistic that by consensus we have to offer patients other alternative and competing things, not just drugs, but neuromodulation when indicated, and have reasonable patient expectations, have the patient buy into the therapy, including deriving and determining whether they have at least a 2-point reduction on the numeric scale. And so there are strategies for managing CRPS. Largely, we're chasing symptoms. We treat the pain as we find it. We use the analgesic ladder, the World Health Organization step ladder approach to managing pain. Mild pain, 1 to 3 out of 10, moderate pain, 4 to 7, and extreme pain, 8 to 10. We use our modalities available to us. Opioids sparingly because there's no evidence in their favor. We do use sympathetic nerve blocks. We do them by convention and by consensus, but the evidence in favor of them is limited to non-existent. There is no evidence, again, in favor of continuous catheters, except for one series of 38 patients. This was actually published in Nagy McHale's book on interventional therapies and the evidence in favor of those therapies. I encourage all of you to seek that book out. Of course, neuromodulation has been shown to work. Multidisciplinary approach works. Sympathetic blocks have been utilized by convention. I have to pay homage to the great Daniel Moore, who in complete treatise on stellate ganglion block. And so Danny wrote 4 books during his career. He didn't always get the credit that he deserved from the Virginia Mason Medical Center in Seattle. He wrote Regional Block, Complications of Regional Anesthesia, Obstetrical Anesthesia, Stellate Block, and he talked about using stellate block. Sam Naruse has popularized the use of ultrasound guidance versus fluoroscopy because you can see certain targets, including the longest coli muscle. Here's lumbar sympathetic nerve block. Everyone in the audience knows how to do it. And by convention, we do these techniques, but the evidence in favor of sympathetic blocks is minimal to non-existent. Remember, you cannot make the diagnosis of CRPS based on a patient's response to sympathetic block, nor can you exclude a patient from having CRPS if they fail to derive benefit. That is not stipulated in any of the criteria that we have available to us. HF10 hasn't been shown, nor has BURST, to have efficacy yet in CRPS. It's really DRG, the accurate study of Tim Deere, Nagy McHale, and others, with 152 patients, showing superiority of the DRG device versus conventional neuromodulation, which actually we have available to us. I encourage you, if you treat CRPS, to read the study, learn the data. Here's conventional neuromodulation, here's DRG, I already showed that to you. We're going through a whole host of things. We're trying to save costs. Cost burden of patients with CRPS can be very extensive. This is a very nice retrospective review of more than 35,000 patients with CRPS, looking at what costs money, when do the costs accrue. The costs actually with CRPS are in the index year, the year before the diagnosis is made, and the year after the diagnosis is made. When you include neuromodulation, you reduce the cost by 50%. Here's the data. You can see at the index year, the year before the diagnosis and the year after the diagnosis, that's when the costs are the highest, both for medications as well as for outpatient therapies and treatment. And then you can see that the diagnosis year, the average cost is $8,500. By 8 years, the costs have gone down 50% when neuromodulation is included as part of the multimodal regimen for CRPS. The cost ratio is 2.17. I encourage you to read the paper. It's part of your handout. Finally, the last thing I'll mention in the last 60 seconds, there are changes now we're trying to realize and starting to realize in the central nervous system. Remember I showed you Penfield's homunculus? Well, now we have something called the functional MRI. And guess what, ladies and gentlemen? The functional MRI is validating Penfield's rendition of the sensory motor cortex, the cerebral cortex, where the sensory fibers are best represented. And we see changes in gray matter volume. We actually see an augmentation in gray matter volume in early CRPS. And that's seen by these slides here. It's a brand new study, just came out, please read it, showing abnormalities in the superior central gyrus associated with early CRPS. And as time goes on, we see a reduction in gray matter volume as patients get better. So this is something which is new on the horizon. I was fascinated to find that this correlates almost exactly with what Penfield told us back in 1937. So CRPS remains a purely clinical diagnosis. You must create a comprehensive differential diagnosis. Do your due diligence. Eliminate from consideration alternative and competing things which can present or mimic CRPS. As John Bonica told us, reflex sympathetic dystrophy is the great imitator, just as in the early parts of last century, syphilis was the great imitator. Sympathetic nerve blocks continue to be utilized by consensus, but the evidence doesn't exist in their favor. Neuromodulation has the strongest evidence. DRG is up and coming. I encourage you to read the study, the accurate study, and early treatment, including psychological support and physiotherapy, determines the success for our patients. Thank you. I'm sorry I went over by 2 minutes. I appreciate it.